So I want to take this opportunity actually to open it up to the audience. We want to give you an opportunity to ask our panelists questions around how some of the lessons learned might apply within the state of Massachusetts. It's really open to you. There are, I believe, 3 folks trolling the floor with microphones. They're holding them up right now. So folks who are interested in asking questions, please raise your hand and they will come to you. I believe there are some hands over there.
Good morning. My name is Josh Archambault, Pioneer Institute, a think tank here. Thank you all for sharing. I have a lot of questions, but I'll stick to 2. The first one is, and I know the focus is on payment reform and delivery reform, but there wasn't much talk about consumer engagement in these plans. You seem to be moving the systems around patients, and you hope that the care provides them better care. But what role do you see for consumer engagement, giving them greater choice, exposure to cost, or being able to choose based on quality? And then the second question is, and Michelle briefly joked about this, about under-reimbursement in Medicaid. How do the reforms that you're proposing reassure those providers that they are going to not see less money than you're currently paying them, or are you promising them if we're able to save money, maybe we'll give you some enhanced payments in the future?
I'll just start with the consumer piece because it is pretty key. Consumer advisory panels are certainly a key part of that in our state. I don't think that there will be a lot of choice because most of the state has only one CCO, but we really want to have very transparent information. We have an all-payer, all-claims database as well. We also have our Robert Wood Johnson Aligning Forces entity that's been doing public reporting around primary care quality and performance, and we want to build on both a plan level and on a provider level, clinic level, that kind of awareness of how are they hitting the targets, and certainly as we are being held accountable by the feds for this, we want to make sure that everyone is aware of where they are in targeting and informing the consumer.
Sure, and I'll say around patient engagement and patient choice. First, Maine, again, we don't have any managed care, and in order to implement a shared savings ACO-like structure, we need to do that under a state plan amendment, and all that really, the reason why I bring that up is because we need to maintain patient choice, so patients will still have choice of the providers they want to see. This started out certainly as a sticking point with certain providers because you can make the argument that it's easier to try to control costs when you can control where your patients can go. We do strongly believe, well, we appreciate that argument, we also strongly believe that the best way to impact cost and quality is through forming relationships between patients and providers, and so we believe that instituting this shared savings ACO model is still going to be a step in the right direction, and patients will still have choice. I also want to mention that both as a part of our PCMH pilot in the state as well as part of accountable communities going forward, one of our core expectations is not simply that practices engage patients in self-management and in their own care, but that they also are engaging patients and families in quality improvement initiatives for the practice or for the accountable community, as well as in the leadership. And about 80% or so of the current PCMH practices have patient advisory boards, and that percentage is continuing to go up. And we are going to be continuing that trend with accountable communities as well. In terms of how do you ensure that providers don't get paid less, I often say that I wish that the reforms we're working on now had been instituted a couple of years ago, and then maybe we wouldn't be having the really difficult conversations we're having in Maine right now about cuts to eligibility and potential cuts to rates. Having said that, being where we are, I think that, well, the fee-for-service system under our proposal still remains. So you're going to get paid what you're getting paid under the system going forward, with the opportunity to have what we do see as payment on top of the current fee-for-service of shared savings payments, so, based on quality outcomes.
Thanks, Michelle and Janine. Other questions from the audience members?
Can you hear me? Okay. Hi, I'm Amy McNulty, and I'm working on an initiative, Community Care Linkages with Mass Home Care, which is really trying to link our AAAs in Massachusetts with the evolving ACOs, ICOs, healthcare systems. I had a similar question more specifically around self-management supports, how you're integrating that, but I think you addressed some of that. But I also, what we're coming up against as we are interacting with physician practices and hospitals and health centers is the need to really sort of have care managers, managing care managers. You know, what do you see in terms of enabling the physician practices and the folks on the ground to really sort of rationalize this resource across multiple care settings? It'd be very helpful to hear your thoughts about that.
You know, the state contracts with the RICOs to do a great deal of what you're describing here, and they're doing it in a variety of ways. It's actually fairly exciting about both their patient engagement supports and practice support. Since we are a come-as-you-are model without certification, we have folks who literally have never done anything else than just a very straight fee-for-service without the care coordination. Our patient-centered medical homes out there and our children's medical homes are a lot further along with this. But we do have a variety of care management. Our teams come from the RICOs. For example, if you have a provider who has not done the things that we're asking them to do now, they will send out a 3-person training team, and they will go on site with each new provider and assess where they are in the spectrum of medical home standards and qualifications. They'll look at their business systems, their IT, the front desk, the quality measures if they have any in place, record keeping and so forth, and assess what kind of supports they need. And then they will go ahead and provide training to that practice, including working with our SDAC and how they can get data. And if it looks like that practice isn't going to have that capability at that point, they'll go ahead and assign someone at the RICO to do that for them. They will be able to create reports that'll work with the provider's system, for example, if they want to look at who's been in for a primary care visit, which families haven't brought their kids in for their developmental screenings, they'll be able to get that quite easily. Best practices are disseminated. They'll create client materials for individual providers that they can then distribute. A lot of the care coordination may be done through the RICO itself, and a client or a family will get a care manager, and then they'll be communicating with the primary care provider on that. One of the biggest things is just the data. And we've got providers who don't have any idea really who they're serving, how much they're providing. And we provide a PCMP the ability to literally look at their top 5 clients, their top neediest clients or the most expensive clients. We're able to connect them with the resources that that client needs. So maybe that client is no longer no-showing every second appointment. Maybe that family is able to cluster their appointments together and get the transportation they need. So that's just one of the ways that our RICOs reach out. The other key thing that they're doing with practices right now is doing training on motivational interviewing. So when clients come in that need behavior change and we don't have that behavioral specialist right there embedded in the team, the provider is able to better work with the client, understand where they're at, and help them make those steps towards changing the behaviors that'll keep them healthier. Hope that answered your question.
Thanks, Marcial.
Hi, my name is Deb Hurwitz. I'm with UMass Medical School, and I'm also right now serving as the co-director for CSI, which is the Chronic Care Sustainability Initiative in Rhode Island. It's a patient-centered medical home multi-payer project. And the question I have for probably Dr. Harris and maybe others on the group would be if you could just say a little bit more about the risk adjustment that's being done. Is that at the practice level, or is it at a larger aggregate level for practices?
So in our model, the risk adjustment is being done on the capitated payment, and it actually is at an individual level and aggregated to the practice and then aggregated to the larger contracting organization. We're using a risk adjustment tool that's been developed by the same folks who developed the DXCG model that's focused on doing risk adjustment, particularly for these types of primary care capitated payment arrangements.
Other questions from the audience? A question right here. And then right here.
Thanks. Douglas Brooks from Justice Resource Institute. A question, in the Massachusetts model of primary care or behavioral sites being the primary care home, can the behavioral health site be the primary care home and make the referral to primary care?
Absolutely. So we spent a lot of time trying to think about how to actually sort of put into practice, again, this commitment that we've made to thinking about integration of the two. And so it's actually structured that the behavioral health site could be the contracting organization, but they have to be the organization that's also delivering the primary care services. So again, the case of a community mental health center that's also delivering primary care services in the context of our primary care clinician plan contracting structure, they could be the contracting organization.
I would just say that, from my perspective, that's exactly the right way to be going. We're focused here on primary care, but the people with serious mental illness in that deep end of the pool that I referred to before, I mean, everybody knows the 25 years lost life, et cetera, et cetera, et cetera. And getting the primary care done where they're getting their mental health care is absolutely the right way to do it. But that's no easier than trying to do the behavioral stuff in a primary care. You can't skimp on it. You've actually got to take care of them. So I just a vote of confidence for that approach that you're implementing.
And I would just add that Oregon, our patient-centered primary care home model was based off of that a behavioral health clinic could be certified as long as they had they were addressing the physical health.
My name is Bill Tenor, and I wanted to ask you about the data exchange that takes place between organizations in linking primary care and behavioral health, and how important is real-time data and getting a communication process set up so that you can exchange real-time data between providers?
I think we'd all agree that it's very important, but I actually would love to have Marcel talk about the work that they're doing in Colorado, because I think that they've taken a really innovative approach.
Great. So first of all, I'm not the data guru. I'm the messenger. Yeah, it's tremendously important. We use claims data, which is necessarily old and sometimes not even accurate by the time we get it. So we are definitely working on that. One of the big barriers that we're facing right now, we do have a state statute that up till recently has provided a higher level of privacy protection to people with mental health issues compared to HIPAA. So we're doing some work on changing state rules and statute relating to HIPAA-covered entities and providers to try to put everybody on a level playing field. As far as the behavioral health organizations, we have a statewide carve-out with 5 managed care organizations. Some of them work and play well, extremely well with the RICOs. Some of them a little bit more of an arm's length relationship. So those that work well together have created delegation agreements, and such data that they have, they're able to share for clients in common under the HIPAA Business Associate Agreement. They can share that data as it's created. The SDAC, of course, will get claims data, which is delayed. But 2 points that are important for behavioral health clients particularly are emergency department and hospital inpatient admissions. And we feel that's top priority right now, both in managing those things and in managing the client's care to prevent those admissions and also to get them transitioned back to the community. So we're working at 2 angles right now. We have a utilization management vendor who has a web portal whereby providers can get authorization for certain services that need to have PARs. One avenue would be allowing that web portal to trigger notification to our RICOs and providers. So if you're a PCMP and your client has just gone to the ER over the weekend, you would get notified based on that PAR from the provider. Not all services are PAR'd. This is really effective only for one segment of the population. So we're also looking at using our SDAC to develop a program script where every time one of our providers hits the eligibility portal, is this client Medicaid, will I get paid? That then would get scraped off with the provider ID and put in an aggregate report whereby the RICO or the provider then can look at the report and say, there's my crosswalk to the type of provider. Oh, great, Mrs. Smith is in the ED for the 4th time this week. And then they can intervene at the client level. So we don't know which path we're going to be able to do fastest, but it's very critical that we figure that out.
Thank you. So we're just at our time. I want to thank all of the panelists for your rich presentations and for offering your experiences up to the audience.